Yay. Okay, so Unit 8 topics. Um, let's just dive right in. Okay, so um growth changes in second trimester. So now we're and I don't know how many times did I say it today, Twinsy? I'm like, we have to remember we're talking about normal today because we're just gonna
And
go.
my response was, is there really normal?
Um, so again, these are the units where we are focusing on physiological normal. Because as direct entry midwives, that's what we want to focus on mastering is normal. So then when there's any considerations or um concerns, those jump out a lot easier. Ask us how we know. That's why we see so much so much. Okay, so second trimester growth, especially primips, they're probably not going to feel a lot of movement until mid second trimester, especially if they have an anterior placenta. So that's something, and that's definitely a variation of normal. So, and even multips, like, well, I'm 23 weeks and I'm not feeling any movements yet. But if they didn't get an ultrasound, that could be what's going on. Um, and we will have a good portion of a unit that just focuses on the placenta too. So don't feel like we're shortchanging you on anything, guys. It's probably just in another unit or in a unit in and of itself too. Okay, so length. So the biggest growth that's happening right now is size and not mass. Mass building is third trimester. So they're long, they're skinny, they have no brown fat. Hold on a second.
He heard long and skinny. He
He's
decided,
not
let me
long
show
and
you.
skinny.
Okay. Sorry about that. The baths did not go as well as a distractive as I was hoping. Okay, so lots and lots of long bone growth. Um, if they are choosing to get the 20-week anatomy scan, it's really helpful for it to actually be in the 20th week. Because all of the charts that baby is getting compared to is based on 20-week growth. So if they're even in the 21st week or 22nd week, there's so much growth happening that even that 1 week is enough time for there to be genetic influencers, like if their dad is 6'7" or if their mom is 6 foot, that those comparative growth measurements aren't going to be as helpful in the 20th week.
And if you have a baby that's measuring, say, large, right? Because the ultrasound technologist is not going to ask you, how tall is your husband?
Yeah.
Right? So
Or
now
have you
you have
ever
a
had a
baby that,
10-pound baby?
yeah, oh, your baby's so big. But they're gonna say, oh, this baby is measuring, really big. Maybe your dates are off. We're gonna adjust your due date. Not thinking that
Yep.
if they beef up your due date, you might be having a 34 or a 35 weeker induced because you're so big,
Yep.
right? Not and the opposite can happen. Oh, your baby is so small. Well, they don't look at the fact that I'm 5 feet tall, right? So before that 18 to 20 week window, most babies are going to look similar in size.
Mhm.
Your genetics start to play into that, even within days, like Jane said, that 21st, 22nd week. By 22nd week, I tell people don't even bother. They're not going to be able to see all the views. You may have to go do additional views now, and that's more money. So I really like, if they're going to do it, I like them to do it within that 18 to 20 week window, so that those genetics don't become factors for us.
Yep. Because after that, once that 21st week hits, and depending if they're even a grand multip, that baby's growth spurts and growth patterns is just gonna just keep
Yeah.
individualizing more and more and more. And
Mhm.
um well, what else was I gonna say? I had another thought. Oh, and in my area, if you're in a shade of brown, they're not necessarily going to say, maybe we should adjust your due dates. They're gonna say, oh my gosh, you're gonna have such a huge baby. We need to schedule your C-section now.
Yes.
Ugh.
Yes.
So that rhetoric is gonna get fed really early, and that can be a really, really huge hurdle. Um,
I have a question.
yeah.
Is that also true for the retroflex uterus? Like by this time, they should be kind of out of the retroflex, kind of and out more of a balloon shape.
Yes,
Yeah,
which
if
makes
there's
the
any,
view more difficult.
and they may not be able to visualize everything on their checklist, and then they'll say, oh, you have to come back in 2 weeks. Well, they're not necessarily comparing those things to 22 weeks even, they're still comparing it to that 20-week
To
list.
the 20.
And so if there's any in the mother, if there's any individualized pelvic tilt anomaly, even like a quarter of a degree, or if there's any, tilt in her uterus or anything like that, and they can't visualize everything on their checklist, they're like, oh, you have to come back in 4 weeks. It's like,
Or you have
wow,
to go to MFM because we can't see your baby's nose.
yeah. And unfortunately, they don't make that time consideration that all that growth that's happened in those 4 weeks, whatever they're saying you have to come back. Because unfortunately, a majority of the time, what would be helpful is if they just sent you straight to MFM and they had their technicians who are used to those kinds of things to visualize. But that's not usually what happens. They usually like, oh, we have to schedule you out 2 weeks, or 20 days
There's
is the
this follow-up,
earliest. And they're
right?
still comparing those numbers or those images to their 20-week checklist, and have fun with your imagination about the mess of the rolling ball that creates. We're talking about normal. That was a good question though. Yep, you're correct. It matters. Yep. And I have had clients who knew that they had an extra 2 degrees on the posterior tilt of their uterus, and therefore like, yeah, my numbers never come out correctly because I have a tilt. So it's nice when they know that about themselves. Unfortunately, they probably went through a whole big lot of mess to figure that out.
Mhm.
Oh. Okay. The big milestones, organ function finishes off in this trimester. Again, more either initial movements or more movements are felt. Auditory, all fetal senses are developing and maturing in this trimester. Hair starts to come in, um, teeth buds start to form, body hair, um, true skin starts to develop in the sense of all the segmented
All the
dermal
layers.
layers.
Yep.
Yep.
Mhm.
Okay.
Otherwise, their skin is like tissue paper.
Yep. Okay, for mom, she might have some reprieve of nausea. Um, she might start showing more, depending on her uterine tint, depending on the depth of her rib cage. Not always. Um, yep, eyes fully develop. Um, you can differentiate sex organs. It's another that's usually the big seller for moms or families wanting to do the 20-week anatomy scan? Stop with the fingers, dude. Okay, quick reference. If you are choosing to palpate in the second trimester, you know, you should.
Know your finger breaths.
Yeah. Okay. There can, depending on how gravid they are, how many pregnancies they've had, how many full-term pregnancies they have, this can be the trimester that has a lot of fundal variation.
Mhm.
Okay. And if she's ever had multiples,
Yeah, then don't
probably
use
just
this.
wait until the end of the second trimester to do your first fundal measurements.
Just don't even worry about it till 30
Just
weeks.
wait. Especially if it's the first pregnancy after multiples.
Yeah.
Or have the conversation of like, hey, muscle memory is a thing, cell memory is a thing. I know you're only 16 weeks, but you're measuring 22, but you had multiples last time, and your uterus is like, here, everybody have all the space.
Mhm.
So ask me how I know. And majority of the time, by the end of the end of the second trimester,
Second.
everything is going to even out to where it's supposed to be. Ouch. I don't always do fundal height at every single second trimester, partly for this reason. Sometimes because I forget, because it's not a piece of information that my brain holds on to, like, I really want this piece of information. Okay. Majority of the time, mom usually wants to know too.
And I'll do finger breaths until 20 weeks or so, because about 19 to 21 weeks, you're going to feel the top of that fundus at her belly button, no matter how much real estate she has, right? No
Mhm.
matter if she's a primip, no matter if she's 300 pounds, if you find her belly button and push down, you're going to find the top of her fundus. I don't do Taylor tape measurements. I don't even start those until 28 weeks, because like Jane was saying, there's so much variation at that point, that anything before that, there's nothing I can do about it anyway. So I don't even start bringing my tape out until about 28 weeks. But I watch for that fundus at the umbilicus
Mhm.
at the 20-week mark. That shows pretty decent on par fetal growth. And so that's reassuring when you can see it about that point.
Most of the time, that's what I do too. Especially because baby could be transverse or in the oblique, and that actually literally means nothing.
Yeah.
At this stage of the game. But as long as, so I tend to not do my first in person until about the 15th, 16th week. So 4 weeks from that, it should be right at the umbilicus.
Yep.
So, and that's a really quick, easy check, or a really quick as you're palpating to find a good spot for heart tones. Because most of the time palpation is actually kind of squishing baby to one side so they stop moving around enough to get a good heart tone
Lock them in.
versus like
Lock them
assessing
in.
position. Yeah, you kind of gotta put a little block on one side to um hey, so third trimester, this is where the bulk is happening. Okay, baby's bulking. There's still lots of length growth, but the order of the day is bulk. This is where they're starting to show preference and tendencies of their positional changes. Right? Vernix, brain development, all the fats, right? Everywhere the baby can put a fat, they're putting a fat, either on the body or in the brain. Yep.
And this is where you might see that the mom is not taking in enough calories. And you'll start to see that these things aren't happening. So if you know that these things should be happening, those are things to watch for. We have a lot of conversations at this 28 plus week about how they're eating and what's going on with baby to help motivate them to continue to take in enough calories and take care of themselves.
Is this big enough for you guys, or do you want me to do like the whole screen? Is the slide big enough?
I can
Would
see
you
it
prefer
okay,
the
but
whole
I'm on
screen?
my laptop.
Oh shoot, I didn't mean to do that. Is that better?
Oh yeah, that's good.
Okay. I was enjoying getting to see you guys on the side, but that's okay. That's okay. It's not about you, Jane. Yeah, joking. Okay, placenta changes. So, and we'll talk specifically more about the placenta in a couple topics. But lots of placenta changes because now it's shifted over into full separate function from mom. So baby's metabolism, baby's respiratory, their sleep-wake cycles, their hunger cycles, like everything's starting to be, what's the word I'm thinking
Can
of?
you let Medina in real quick? It's kind of coming online for itself and it's fully sufficient now.
How do I do that? Oh, there we go. Okay. Yep. Baby is starting to become an individual unit and not in such synchronicity with mom's system. That makes sense. Um, a big time frame, and we'll get more into this later. I'm not going to just tease you with this topic and then leave you hanging. But this is where you can start to see important growth discrepancies. And one of them being the establishment of, or how the placenta shelf is or is not developing. Okay, and by that, I mean this. This is where you can see it's not flat, it's not flush, it's developed, like it's an extra layer, it's its own layer on the uterus. And this is one of the things, if they have a late term, this is one of the things that they assess when they grade the placenta. And again, we will do a whole topic just on the placenta too. Right now, we're just talking on normal. So this is the normal development, is when the placenta shelf develops. And this is how it sets up function to detach appropriately.
Oh, I can see that.
What's that?
Pearl says it looks like a hogan or a lodge.
Right? Mm-hmm. Yep. Okay. So pop-up question. And we're gonna take 10 minutes. So answer these two questions. You can write it out on notes and then email a picture of it. What is blood volume expansion and when does it happen? And then if anybody needs a bathroom break or snack break, and I will set my timer, but in that 10 minutes, please answer these two questions however you want to answer them, and then email either notes, document, screenshot, however you're doing it.
Hey, Jane, can you let in Auntie and Medina, please? I think they're in the thing.
I'm in.
Did Medina get into? Oh, yeah. Okay.
I'm here, but I'm driving.
Okay. Thank you for letting us know. Oh my gosh, you guys, I kept asking if people were back in here. I was muted the whole time. Cheyenne, I was trying to kept asking you, did you get a haircut? Looks really nice. I'm just talking to myself over here. It's okay.
Well, it's fine.
Is everybody back?
I will be in a second, but you can go on without me.
Okay. Okay. Everybody get their email in? Good to go? Somebody give me a thumbs up or hey. I'm joking.
So can I, when I get home, can I submit this?
Yes, ma'am.
Thank you.
Mm-hmm. So I sent you a message and I was like, she's driving. Don't make her read something when she's driving.
You do that to me.
I'm sorry. That's literally what the message said is like, don't worry, just get home safely. Okay. Everybody else, get your email in. We good to go? Okay. Here we go. So, this is a prime example, blood volume expansion. This is a prime example of little inconsistency in the literature. Okay, but first, okay, what is it? Total blood volume is literally doubling.
Doubling.
There we go.
Doubling.
Okay. So lots is going on. This is probably the number one thing that is what's causing that second trimester energy slump. And this is where you could probably gonna see a little dip in the hemoglobin. Some things that they might have experienced early in the first trimester might come back around. And this is probably one of the hardest places to encourage grace because they just got out of the suck of the first trimester and then they're feeling amazing and then they were doing all the same things and why do they feel terrible again? Okay. But this is a very, 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 very critical developmental point for baby and placenta. Where you're going to see, oh my gosh, look at all the information that I included. Sorry. I really went into a lot of detail, guys. But I mean, but this is literally what I'm talking about. This is so much is going on. Okay. And we'll talk about our H factor. This is later. And when we do our unit on the placenta, we'll just like what we were saying earlier with Pearl, like we'll be revisiting this 2, 3, 4 times over. Because this developmental window, and when I'm talking with women, I'm usually talking between 20 and 24 weeks. Okay. Some literature says that it starts happening in the 16th week. Some literature says it's done by 23 weeks. It's very individualized, and I've seen it be very reflective of how gravid she is. And definitely reflective of first trimester self-care, big time. So I kind of cut the average and scoot it back a little bit. And when I'm talking about it, I'm talking about the 20 to 24 week range. There, because even if individually it's starting in the 16th or 17th week, they're probably not going to start feeling the effects until 19, 20 weeks. And then it's not going to register until they're feeling effects, right? Do you talk about it any differently, Twinsy?
No, I tell them, hey, I tell them to anticipate it, especially they get to that second trimester appointment and they're like, oh my gosh, we're feeling so good. You know, I'm not throwing up anymore, this and that. And I say, okay, but if you wake up one morning by 28 weeks and you feel like you got hit by a truck, you're not coming down with the flu. It's probably blood volume expansion. And a lot of times people that have had facility births, they're getting blood tests at this point. They're getting blood tests for the glucose tolerance test. They're getting blood tests if they have a Rh negative blood type. And a lot of times what I'm finding is, like Jane was saying, that we could expect a drop in their hemoglobin to do all of these other testing and all these other things for something that is a physiological dip and should be expected. You shouldn't be surprised to see someone go from a 12 to an 11 or a 10.
It's actually really the worst time to be doing a lot of these tests in
Yeah.
in this time frame. It's really, I mean, there's other reasons why a lot of these tests are setting women up to fail, but this is definitely like doing it during blood volume expansion. It's amazing. It amazes me when someone gets, oh yeah, you're totally fine and within the realm of normal. Like holy dang. This can also be a window of time where breakthrough bleeding happens because the placenta will do a lot of movement, and the placenta basically doubles in size and weight. That reflects this blood volume expansion. And so it can get, especially if it's a low-lying placenta, it can start being pretty heavy. And if it's not moving up, it actually, and not to say that it'll like slip down, but it can get kind of heavy if it's like low lying on the right side. I'm gonna stop there because we'll talk more about concerns later. I'm not talking about concerns. Try to give us both a little pep talk. Like we have to talk about normal. But that is, I mean, it is a variation of normal too. You know, low-lying placentas, some low-lying placentas is a variation of normal. But it is something definitely to keep in consideration if you are working with a woman who has stacked pregnancies. Or had a suspected miscarriage within 1 to 3 cycles, 3 months prior to this conception staying. And
And I'm finding
I
huge
think it was in the
correlation
fertility,
between, yeah,
the
I'm
fertility
finding
lecture
huge,
when we were talking about like leaps and stuff like that. That could come into play now too.
I'm also finding a correlation between women who have done Plan B, where it did not work and they've got a pregnancy.
Yeah, if they're if they're within 6 to 9 months, a year or less of intentionally getting off of hormonal birth control and they get pregnant, I mean, there's a very high likelihood that they do have a lower lying placenta. So if they call you up at 17, 18, 19 weeks, I mean,
I don't know if that's me freezing or you, Jane.
phases of blood volume expansion. Okay. Okay. Fluid level, fluid level is, I mean, just the difference between 20 and 37 weeks. It's doubling too. And this could be emotionally triggering for somebody if they struggled with any sort of eatings or body image. This could be a pretty hard phase of allowing themselves to have this physiological normal process of you're literally doubling to doubling and a half all the collective fluids in your body. Okay, and this is so this one is talking about there's still a lot of fetal or a lot of placental structure and expansion that is happening at the beginning of blood volume expansion. And this is going to correlate when we talk about SGA, IUGR, all that kind of stuff. This is where the precursors of those considerations when we start talking about concerns and anomalies, this is that window where a lot of that foundational struggle is laid. Okay, other things that are going on in blood volume expansion. Okay, if there's twice as much blood, then there's twice as much oxygen, then there's twice as much nutrients, there's twice as much, like this is where the growth rate, not growth rate, the foundations of baby having the structural capacity to build weight in the last 3 weeks. Blood volume expansion is where all those building blocks, all that foundation, all the structure is
All
first started.
set. Mhm.
Yep. Okay, any questions? Anything from the reading coming up? Any reflections about?
I just posted a
Shoshana,
question.
yeah, Shoshana asked, will living in a higher altitude make a difference in a growing placenta?
Good
Yeah.
question.
Yep. Unfortunately, I don't know all the ins and outs of that. I mean, we should network with some Colorado midwives and see what kind of structural difference they see in placentas, but yeah, I would imagine
I know that some of the Utah gals have talked about some of that. And they're just under, I think, like 3,500 feet, 3,500 to 4,000.
yeah, I would imagine
But
that,
definitely people in Denver, Mile High.
yeah,
I'll reach
would-
out to Michelle.
I went to
I
that Air
would
Force.
anticipate probably deeper cotyledons, maybe wider placentas, because they have lower oxygen levels in the air. They need more surface area to
Right.
feed the baby all that it needs.
And I would argue that evolutionary wise, you probably see fewer single umbilical arteries in those situations. That'd be an interesting rabbit hole to go down.
That would be interesting. I
Shoshana,
would, yeah, I would imagine that early trimester losses with developmental anomalies in the cord would probably be higher miscarriage rates for 2 VCs, 1 VC. I think it would probably be interesting to see if they have a higher occurrence of 4 VCs.
right? Yeah,
Yeah.
that'd be fun. That'd be a fun rabbit hole to go down. Sorry,
Yeah.
Shoshana, you were starting to say something.
I was just gonna say I took a trip during one of my pregnancies to Colorado Springs, and we actually went further up higher in the Air Force Reserve Park, or the Air Force Park up there. And I thought I was dying because I couldn't get enough air.
Yeah, I bet, because I mean your system was set up for a lower altitude, and depending on when I mean it has a lot, it is one of the considerations of why they tell you not to fly, you know, is oxygen capacity or transference. There we go. That's the word I was looking for. Placental transference rate of oxygen.
And that altitude sickness and pressure changes.
Good question. Okay, so second trimester checkups. Things that you might consider doing, not doing, like we kind of touched a little bit on that. We don't neither one of us bundle tape measure every single time for a second trimester. Lots of conversations. I try and create lots of conversations around nutritional need, blood volume expansion, because I know, I know what potentially we could be seeing in the third trimester. If they start conversations about gestational diabetes, that's a big thing. That's going to be a big conversation in a lot of our communities. So what's actually going on? Okay, because yeah, we can all say all kinds of stuff about it, but what's wait a minute. Okay. Okay. So there is a physiological normal shift in insulin production, insulin sensitivity, and insulin utilization in the progression of pregnancy. Okay. Now, if we're saying that majority of women are, well, almost all women are either in the middle or definitely have started blood volume expansion by 20 weeks, look at how that starts to climb. The insulin change really starts to change. Here, son. Here, now. Don't touch them with those spicy noodles. That you go half.
I think you're freezing, Jane,
I'm
or maybe
frozen.
it's me. Is it Jane?
Yep.
Okay. So you started to say we see it increase, those needs increase, and then it totally cut out for me.
Better?
Yes.
Okay. So if we look between 20 and 24 weeks, there's a lot happening, right? And that's right in the middle of blood volume expansion. This is where, again, a lot of foundational work, either good, bad, or otherwise, is happening in the placenta. Okay. This is the start of the systematic divergence of mom system versus placenta and baby. and what they're functionally going to be able to do in 10 weeks, it's a lot. There's a lot going on in 20 to 24 in blood volume expansion. And where's that thought going, twin? So
Well,
this is physiological normal. Okay, this is the physiological normal change in how a pregnant body accesses, utilizes, or produces insulin is the dotted line. Okay. That's
and you see that they actually need that increase.
they need the increase. And this is why, if you really go down the rabbit hole, the American Diabetes Association refuses to call GDM GDM. They're like, it's not. It's how the body is normally changing its needs for insulin.
And if you think about how and when they do it between 26 and 28 weeks, look at from 20 to 28 weeks, the increase. How many women are going to fail their 1-hour glucose tolerance test? And it's just a completely normal physiology of how their bodies are processing the needs of their pregnancy.
Right in the middle of the physiological normal spike in demand, we're telling pregnant bodies to fast.
And then drink
Wonder
60
what's
grams
gonna
of
happen.
sugar.
Wonder what's going to happen when we give them 60 to 90 to 120 grams of sugar, depending on which test that the lab is using. But what do we know? We're just direct entry midwives. Okay. Now you throw on top of this pregnant body is any variation of brown. Okay, because they're not set up for modern Western diets. Their bodies
Right.
don't like it.
And so the
Yeah.
things that are happening in a brown body, they're working twice as hard.
Mhm.
And so any teeny tiny abnormality can then go gangbusters because the body doesn't have the I don't know if even evolutionary predictors for that is really the right term, but there's a capacity of not being able to process those normal things because it's not part of their generational diet.
Mhm. And then let's compare them to the statistical, what they're supposed to fall into for white non-pregnant bodies in the 50s.
Mhm.
Just saying. I don't have any opinion about this at all. Okay, so this is the normal shift. This is what the body needs to do. Okay, and where you see it crest at 36 weeks, okay, after that, after a steady build, okay, this is where you can see IUGR, ICP, SGA, but if they're telling them that, they're GDM positive, when that the biggest climb is supposed to be happening, and then they're putting them on metformin or insulin when the physiological normal biggest climb needs to happen. I wonder why. Okay, here's another one. Look at second trimester. Okay, we're just looking at second trimester. The biggest crossover shift is happening in second trimester. Okay, in insulin sensitivity. Okay, this is the physiological normal shift. Okay, but then what's the answer? Well, let's put you on insulin. I told myself I was going to do an excellent job of just sticking to physiological normal. Sorry,
Did you
guys.
see it on my face?
A little bit. I was like, yeah, I know. I'm going against my own wording. Okay. But what's starting to climb at the end of second trimester? Fetal growth hormone, placental growth hormone. Right? And if they're failing that test and then getting slapped on metformin or insulin, why are we surprised that we're seeing grade 3, grade 4 placentas?
Mm.
I mean, I don't know. I'm just a midwife. Sorry. But I mean, we got to know their side to create these conversations, right? To have, because we're all gonna, and we all have, I know Twinsy and I, we've had the conversations because this was their previous experience, right? And how do we then justify that we don't actively test for GDM? Okay, so knowing that this is all the physiological normal shift, this is the credence behind our conversation of like, well, it's actually really not what your insulin is doing, it's actually what you're putting into your body. So let's focus on that. So that's where I'm trying to go with this conversation. That's why I'm trying to give the visualization of this massive physiological normal change that is supposed to happen just in this 20 to 24 week window. Okay. Any questions or thoughts? We're going to come back to this when we talk about nutrition later too in this unit. Right? Prenatal markers, blood pressure and UA. Okay. It kind of depends. For me, it kind of depends on when in the second trimester our prenatals are happening. Like I said, for me personally, I usually do the first one right at the end of the first trimester. Okay, I like to do everything then, get all the comparative baselines. Okay, then depending on what they're telling me that they're experiencing, if I'm catching them right before blood volume expansion, I'll probably do them all again, you know, especially the hemoglobin. And I think I got that next. Yeah, hemoglobin. You know, if they didn't have labs, if they did have labs, like if they went in for the 10-week dates and they did have labs, I probably won't do a hemoglobin until right before and then after blood volume expansion. It depends. UA, if they're talking about if it's the middle of summer, I definitely want to do the UA. Probably almost if the majority of their second trimester and into the third trimester is in the summer, yeah, I'll probably do the UA more often than not because electrolytes, man, like that can be so hard. And if our electrolytes aren't good, I had one gal, she's like, oh yeah, I've been peeing clear for weeks. I'm like, can we not? Like I actually don't like that. Because if we don't have electrolytes in our body, like all of our normal cellular structure or function is struggling. Like we need our salts, right?
Which will then make your baby increase its own glucose parameters.
Yeah. Yep. And then, exactly. So if they're struggling with their electrolytes prior to blood volume expansion, and then it continues after like the 28th week, baby's metabolism is going to struggle. Baby's own electrolytes are going to struggle. Baby's glucose is going to struggle. They're going to struggle to be able to put on good brown fat. Like, wow, I'm really not taking my own advice and talking about physiological normals.
I was going to say, we just went sideways again.
I
You have to
did.
forgive us, guys. It's because we've had a string of really, really abnormal. So that's become our normal.
No,
Which
this
isn't
is
good.
helping me.
We're not even trying to normalize that either. But this is where our brains go when they're like, oh yeah, I drink a gallon of plain water every day. I'm like, no salt? Oh no, I don't want any blood pressure concerns.
Yeah,
So
I
I
don't
don't
want
put
to
salt
salt.
on anything. Like, but could you? Could you please?
Would you please? Would you please? Could
Could
you
you
in that
please?
box?
Yep.
And I've had a few ladies that have come into care a little bit later that are like, why do you want to do a UA? I've never had a UA all the way up until this point, except for the initial labs. Because there's some ACOG guidelines now that are saying that the UA isn't necessary. But my argument to that is that it's not necessary because they're doing more mid-pregnancy labs. So we don't have those. So I'm looking to the UA to tell me, are they throwing ketones? Do they have glucose? Do they have leukocytes? Are they throwing protein in their urine? Like those are good markers for me to know whether or not I need to look into something different. Whereas ACOG is just automatically running those labs now. And so they're getting away from the UA. So if as you guys are going down the rabbit hole of this, you're like, hey, they're giving us kind of outdated information because they still are recommending UAs. You have to understand that part of that is due to the resources that we have. And those are still your best defense
Yeah.
against things that are happening there. A UA is going to alert you to something. Looking at the color of their urine is going to alert you to something long before they're going to be willing to get labs, if you can get them at all. But that is
Or
the
even-
biggest change that I've seen lately.
Or even if before they feel it. Okay.
Mhm.
And if you're supporting within your community, maybe you choose to do bi-weekly visits through the second trimester. Okay. Our range is ridiculously large. We don't usually that's not usually a feasible option for us. Okay. The difference in my preceptor used to do it. She went from doing it all the time to ACOG recommendations change, and she was a CPM, and then she never did them. Right. But blood and urine doesn't lie. And that's
Yep.
usually where you see the first changes before you see them symptomatically. Okay. You'll usually see specific gravities start to change before they have systemic migraines.
Yep.
Okay. So those subtleties in the UA, especially if you are honestly lucky enough to serve, if you choose to just serve within your community where you might be able to see them every other week, you can tell a lot. Okay. Especially the seasonal changes, and sometimes it can be a very, very helpful piece of tangible information to then create the rest of the conversations of why am I telling you these things? Why am I saying this is really important? And maybe you don't feel this, but baby's starting to feel it.
Mhm.
Okay. Position and presentation, I usually don't chart much. I'll chart reactivity, that there's lots of movement, that they're feeling movement. If mom is really uncomfortable, then we might talk about things to encourage baby to choose anterior versus posterior if mom is uncomfortable. But as far as baby's choice in position, especially if she's a grand multip, it's like the freaking Astrodome in there. Like baby's got all kinds of space to make all kinds of movements. So as far as baby's choices in position in reference to labor prep, don't worry about it right now. Okay. Fetal heart tone changes. This can be, especially if you're doing a checkup in the middle of blood volume expansion. This again can be a very helpful tool, tangible tool. This is what I'm seeing. And we don't have a lot of hard numbers at our disposal to create these conversations of this heart tone is telling me baby wants to eat more. Baby wants more
Please.
electrolytes. Okay.
Please and thank you.
And this is also where you start to learn baby's patterns. So that could be a really helpful piece of information, reflective piece of information later on, once you see, well, this is a big shift in the baseline. Okay. That's a pretty big jump in the range. Okay. And again, please don't feel like we're teasing you with this. You know, this is laying the foundation for our first in-person, and we'll be going back over this 2, 3, 4, 80 times in the next year and a half. Okay. Maternal mental health. Okay, this can be another huge thing. Self-care. And if she's reverting into that second trimester slump, feed your brain, feed your body. Your body is growing a body. Please give it resources.
And sometimes I'll check in with him at this window. Hey, how are you keeping things down? Tell me a little bit about what you're eating. Tell me how long, when's the last time you ate? If
Mhm.
it's been over 3 or 4 hours, I reiterate the need for small, frequent meals throughout the day while they're awake. And so a
Yep.
lot of times you can tell a baby, especially if you've got a baby with a flatter baseline, or if you've got a baby that's a little sluggish and not reactive, and you've tried, you've talked about the positional things, you've talked about the other things. A lot of times women will self-report that there's a 2 or 3 week window where they feel a little disconnected or a little off. And I kind of go back to how are you caring for yourself in this window? What's happening? You know, most women, I don't know about you, Twin, but I've been getting a lot of, oh my gosh, I'm getting so fat. I'm so huge. Look at how
yeah.
much I'm showing already.
Yeah. Especially if there was a jump. Like if they went
Mhm.
from like hardly showing to then actually looking like 5 months pregnant. This can also be a really good time if in her previous pregnancy histories, if she experienced if there's huge markers. Okay. If in the last pregnancy, say she failed the glucose tolerance test, and then in her last pregnancy, everything took a sharp turn left. Okay, and now we're coming up on that marker, that week gestation in this pregnancy. For some women, just having the different plan of care of having your support versus having to go to the clinic, that's enough. Okay. For some, it's not. Okay. So if you, through previous history counseling, know that, or if, you know, if there was a subchorionic hemorrhage, which then led to non-viability, late miscarriage, you know, if there's big emotional markers, this could be a good time to revisit those two.
And don't think that those things are abnormal,
Yeah.
right? Like those things actually are normal. There's
Yep.
a huge hormone change that's going on, especially if she's having a girl. Like there's all these different things that we're not being taught in the obstetrical model of care.
Yeah, and that's a huge point too. Okay. If known or unknown, if this is a female fetus, okay, at between 22 and 26 weeks, there's a whole nother set of hormones developing. Okay, so now mom has her hormones. Then there's the placental hormone shift. Then the female fetus is developing their hormonal panel, not pattern, panel. Both are true.
Both are true.
Yep,
Their pattern of behavior and growth and metabolism and all of that.
yep. Because what's the big thing that's happening is that female fetus, they're developing all their ovums in that time frame. Okay, third trimester. Okay,
Oh, I love this one.
what's that?
I love all these freaking pictures, but I
Thanks.
really like this one. I know, I don't even know where you commandeer these things at.
Oh, I'm sleuthy as I'm picture
I know
ninja.
you are. I know
Mhm.
you're a picture ninja. I try to find them and they all just look like cartoons and I just stuck it.
Okay, revisit of glucose changes. Okay, placenta growth hormone and fetal growth hormone is just rocketing off the charts. Remember, this is where this is where babies bulking. Name of the day or mission of the day is bulk, bulk, bulk. Okay, so that being said, placental growth hormone freaking shooting off the charts, right? To accommodate baby, because now baby's metabolism is its own. Okay, to a certain degree. Now mom has to feed her metabolism and baby's metabolism. So if she's kicking ketones, UA, baby's deep in ketosis. You're going to see massive variabilities in the baseline. Okay. And honestly, that's usually not that I'm trying to like guilt moms into this, but we're not thinking that way. Women aren't thinking that way. Okay, because it just hasn't been explained to them that that's physiologically what's going on. Okay, you're not feeding one metabolism. You're feeding two separate metabolisms. So if your metabolism is struggling and saying, I'm hungry, baby's been saying, I'm hungry for the last hour. Okay, insulin sensitivity is at a low, not because we don't need insulin, but because now baby's pancreas is utilizing its own insulin differently. Okay. Okay. Prenatal markers, definitely doing BPs. I'm definitely doing BPs. I'm definitely doing UAs, and I'm definitely doing heme. For sure. Definitely, definitely at the 36. I'm for sure doing a hemoglobin at the 36 because if there needs to be some encouragement done, I still have enough time. Even if she goes into spontaneous labor at 38 weeks, unless she has a history, I might do it at 35, 34 weeks. You know, position. Okay, yep, revisit. Again, knowing I'm using tape measure by this time. I'm definitely using tape measure by this time because I really want to stay in that ±2 range, or I want to know what else is going on. Okay. But I have had an experience of undiagnosed true IUGR, and that was an ugly, 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 ugly feeling. And I kind of saw the writing on the wall. She was really struggling with diet the whole way. So, but we're talking about physiological normal, Jane. I'm definitely using tape measure in the 3rd trimester. Right? I want to make sure that baby has the ability to effectively bulk. Oh no.
The other thing that's a good indicator for why we use the tape at this juncture is because, again, irrespective of your real estate, your uterus is going to meet these milestones. And if they don't, it doesn't matter if she's small, it doesn't matter if she's big. If they are not meeting those milestones, there's a tangible thing that you can show them. You're not just busting their chops about protein and fats or whatever. You can say, do you see this? I expect your belly to measure XYZ. And we're not seeing that. So, and then you offer whatever supports you're getting. And I've even started doing hemoglobin in the 34th or 35th week because it's been taking my ladies a couple of weeks to decide that they want to go with my protocol. And when I was waiting until 36, I had a couple of precips that were they were really hard. And I wished I had a little bit more time to try and bulk up those numbers. So I've been incorporating it.
Okay. Is she frozen or am I frozen?
She's frozen. She's frozen.
Okay. So, I may also
38
increase.
weeks. Yeah, if you have a woman who's
You
38
froze up,
weeks,
twin.
if Can you guys hear me?
Like two
Stupid,
and
I
a half
hate this thing.
thoughts.
Yeah. If you have a woman who's 36 weeks and she's only measuring 31, now you've got a little bit of time. So if you're doing some of those things earlier, you can kind of stack your deck a little bit for what you might be seeing in the birth.
History, previous
Yeah.
experiences might be another reason to do multiple hemoglobins in the early third trimester. Lifestyle choices. You know, I shared with you guys some of my protocols with moms that use cannabis. I'm actually checking hemoglobin I choose to check hemoglobin every single visit for a cannabis using mom. Partly because I want to know, and partly because I want to come back to that conversation or expand it because it's serious. It's serious, and that's my line. That's part of my line. Okay. Oh, also another thought with what Jade was saying about fundal height is not reliant on how much adipose tissue mom has. It is also not reliant on baby's positional choice either. Okay. Unless they're straight sideways. But I
Yeah,
mean,
yeah.
through palpation, you'll know. Okay. And you want to start seeing their pattern. Okay. If they're measuring -1, okay, so if they're 36 weeks gestation, but they're only measuring 35, as long as it stays that way, that's that baby's pattern. Okay.
Right.
But then at 37 weeks, you still want to see that -1. Okay. But like my case with True IUGR, at 34 weeks, she was measuring 34 weeks. At 37 weeks, she was measuring 34 weeks. At 38 weeks, she was measuring 34 weeks.
34 weeks.
But and we'll get into that too, but that time frame is very telling of what's going on. Okay. So again, tangible information, knowing baby's patterns, okay, and seeing it, and same if she's measuring +2. Okay.
Right.
Very, very common if they're more than 4 times gravid. Okay. They tend to be on that plus scale. Okay. If the bulk of her third trimester is in the summer, she might be on the plus side, but it's probably in our body's best interest in the middle of the summer to have a little bit of extra intrauterine fluid. Call me crazy.
And you're looking at what is that baby's pattern, right? Like the majority of your job is not even dealing with the mom at all, really. It's getting to know the baby so that you can help the mom, either think about different choices or be aware of what's happening with her. But a lot of these things, fundal height, gestational age, all of these different things are what you're finding that's telling you something about the baby. How is the baby doing in these different windows?
Yep.
And I kind of tell people the baby's voice is the hardest one to hear. That's who you're actually hiring me for. And so a lot of times, like when you think about it in that regard, it helps women go, oh, yeah, you're actually not telling me this to tell me not to use cannabis or tell me not to eat muffins or, whatever it is. Like you're actually seeing a tangible difference in maybe it's just baby size. Maybe it's baby's heart function, like all these things. You're going to learn what all these baselines are. So then when something is outside of that, here's your little thing. Oh, well, what is her fundal height? Well, what's been the pattern? Like you can go back and reassure yourself that everything is fine. Or you could also go back and pinpoint where it started to go south and give yourself enough time to hopefully turn that around for them.
Mhm. And some of us, I mean, some of us live in states where, I mean, depending on our choices of going CPM or not, or even licensed DEM, regardless of what our state may require or how under the radar we fly on our reservations, these are good for your own discernment,
Mhm.
just like what Twin was saying. Okay, retrospectively, you can go back and pinpoint pertinent windows. If these changes are happening in pertinent windows, that can be huge pieces of insight of the difference between dealing with SGA versus IUGR. Okay. Oh, there's like a, okay. So, palpating position, okay, being familiar. And again, we're going to see this multiple times. We're going to get some hands-on practice. I'm going to come up with, oh, I'm so excited. Auntie, I am going to steal that styrofoam practice model. I'm gonna make one for us for our first one. I'm so excited to be crafty about that. Anyway, so baby's presentation is not just about baby positioning themselves for labor. Okay. And now it's not just about mom's comfortability. Comfortability.
Comfortability.
There we go. This can now start being about baby's inability to pick a position. Okay. And that can give you insight about where placenta is located. If she chose not to ever have an ultrasound, babies are pretty smart. They tend to be opposite of where their placenta is. It's like this weird self-preservation
Weird.
that they have. Yeah, it's pretty amazing. If there's any muscle tension, okay, that can influence baby's ability to pick a certain position. Jane, we're talking about physiological normal. Anyway,
It
this can
it
be
is.
just like fundal height, it can be very, very helpful. Sometimes it's the best retrospective piece of information. If baby like to stay on the left side, and they're always on the left side, and they're always on the left side, and they're always on the left side, and then all of a sudden they're on the right side and breach.
That should give your spidey senses
Okay.
a tingle.
Yeah, that's throwing up some radar pictures. Flags, not pictures, flags. Okay. So, just encouraging why you might choose to do reoccurring palpations in third trimester. There, that's the thought I was trying to get to. Thanks,
Yes.
guys, for tolerating my rambles. Okay. Same with fetal heart changes. Okay. You want to see the consistency in baby's personal pattern, but then you also want to see sleep wake cycles. Okay, so the ranges are going to start to get a little bit narrower. Okay, mom is going to start probably more reflectively through conversation and questioning, saying like, oh yeah, 6 o'clock, it's like freaking bouncy house in there.
Yeah.
Okay.
Witching
No,
hour,
like,
witching hour.
yeah, like, oh no, it's 2 o'clock, baby's always really quiet. You know, like, oh yeah, we're having our prenatal during baby's quiet hour. Okay. This can also be a really good time to kind of plant that seed in mom paying attention. So then maybe at the end, when you're talking about kick counts or, you know, or has a reflective like, yeah, baby's movements were really frantic. Okay. You've already laid the conversation of noticing baby's patterns. Okay. If the baseline is kind of narrowed, if the range is kind of narrowed, okay, because there should be, and again, I'm not leaving you guys hanging. We'll talk more about what the actual ranges and baselines look like. Okay, there is a shift, there's a settling. Okay, as baby has more pattern sleep and wake cycles, their range will narrow down.
Reflect that. Mhm.
Okay, but you'll also see variability if you're doing basically a home BPP where you listen for 10 or 15 minutes. Okay, you'll see nice big spikes whenever they see it. You see the kicks in baby or in the uterus. Okay, and you'll also see their baseline as they get closer to labor. Usually doesn't start for most babies until after 38 weeks. Okay, there's a settling. If you're still seeing the same range in baseline that you're seeing at 27 weeks, and there's, okay, because we're taking the holistic model, so this is the whole big picture. That's one piece of a very important picture of the puzzle of what might be going on. Right? So again, we're learning baby's pattern, but then we also want to see the general following of what you would expect at a 39. You wouldn't expect a 39-week fetus to be frantic and as active and as a huge, like 30-point range with a 160 baseline that you would see in a 30-weeker even. Does that make sense? Any questions? Okay, and again, there are normal physiological shifts in mental health. Okay, she's nesting, she's preparing, she's doing some process of reflecting of previous experiences. I personally, as a grand multip, I kind of don't care how many times she's birthed. There is a normal processing of the unknown, worries. Okay. But that doesn't necessarily mean that I'm registering her as a PMAD situation. Okay. I actually, in some ways, I kind of get more concerned when they're 30. Oh, no, it's fine. No, I'm not thinking about anything. I'm
Everything's
like,
great. Everything's
really?
great.
You're not thinking about anything? Well, you should be. You should be thinking about a few things. Okay. So in that sense, to me, the absence of reflection says a lot more than,
Is also a thing.
yeah. Yep. Normal prep. See, there you go. Like there's a normal process of prepping. You know, how am I gonna, like, oh yeah, yep, gotta get my mindset back into the diaper duty and, you know, um, I personally find the most common the frustration of not getting enough sleep.
Mm.
Okay. So sometimes just normalizing the conversation of like, actually, for most women, that's helping your brain prep to babies, a newborn's normal sleep cycle.
Great pattern.
Oh, yeah, I didn't think of it that way. Okay, well, that makes a lot more sense. Like your body, your brain is actually trying to prep now, knowing, especially if she's a grand multip, her body knows what's coming, her brain knows what's coming. Okay. It's trying to prep you to get back into that functional cycle of lack of sleep. Woo, here's a
We
fun one.
also use that segue in talking about nutrition. I get a lot of people that say, I couldn't possibly eat every 2 hours. You're just asking me to eat too much. And I ask them, how often will you be nursing? How
Yeah.
often does your baby need to eat? You actually need to feed yourself along your baby's metabolic timeline. And if you get in the habit of doing that while you're pregnant, then that habit carries over and you're making better milk. You're able to meet those needs as well as reduce some of that fatigue because you're meeting a caloric load that sustains that and supports that. So that's how we use a lot of that.
Mm-hmm.
We kind of try to
And one
tie it
aspect that
into what baby is doing.
Yep. One aspect that I add to that conversation, I'm sure that you do too, Jade, is there's a caloric need to healing from labor. Okay, so you're recovering from pregnancy, you're healing from labor, and you're feeding a whole nother body. So yes, get into the habit now of frequent eating. Yep. Okay. And so first off, what's the normal need? What's the change? What does that change? How does that change? Need change? How does the need change? There we go. How about I just read what I wrote? I'm okay, guys. Okay, so here's the science of it, right? Somebody broke down what's the actual kcalorie caloric daily increase between each trimester. Okay. Well, us nerds, we like this. This tickles us. Okay. That's going to overwhelm a lot of conversations. Okay. So then if we break it down, make it simpler. Okay. Okay. Here's what the need looks like. Well, sometimes that can still feel very overwhelming. Okay. So let's make it simpler. Well, this is just the protein increase. Okay. A little bit simpler if we just focus on protein. But for some women, depending on pregnancy history experiences, adolescent experiences, body image experiences, this is still a lot to digest. Okay. So how do we make this simpler? There it is. Okay. 60, 90, 120 per trimester. That's our goals. Minimums. This is the
Minimums.
minimums.
This is our minimums.
Minimums. Okay.
Animal-based, please and thank you.
Yep. Now, ideally, and especially if we're supporting in our community and we've maybe had some time to have conversations, maybe this is somebody that we have visited with them about fertility. Okay, and we've already had these conversations like just in our normal menstruative cycle. Okay, 60. So that 60 should just be our bare minimum. Okay. If we're trying to conceive, it definitely should be bare minimum. So that should be carryover from 6 months, 9 months prior to conception through the first trimester. Again, this is bare minimum. Okay. Ideally, if in our midwifery fantasy minds, what would you say? I would say 120 by second trimester and adding
I
probably 20 grams per month.
I would say 85, 120, 150, 160s
Yeah.
in the third trimester.
Singleton.
Singleton.
This is singleton. Okay.
Singleton.
And honestly, for me,
Multiples
this isn't
easily
even.
150, 175, 200.
Oh, definitely, definitely. And as a gestational geriatric grand multip, I would even shift these over if she is over 35 too. Like, so this really is, and I wish I could tell you that this is the easiest part of our job. Arguably, it's the hardest. Okay. So how do we make this easier? Okay, oh yeah, history of GDM. So if there's, please, thank you. If they have a previous pregnancy where they just got all the dumpster fire thrown at them because they're the wrong shade of brown, and they're going to a border town hospital, this is like a horrible situation, right? And they saw a white male obstetrician who is over 45, and they just got the whole ugly GDM book thrown at them. Okay. They're going to have a lot of emotional points around food. And I can't tell you how much of my heart I wish it was different, but that's a huge role that we're trying to fill and change in our communities.
Mhm.
Okay. So it can be very tender. It can be very hard to incorporate the suggestion of reflective food journaling when there's that kind of history. Okay. This is sometimes an area where I might lend out my glucose meter and I talk about when should you test, what are you looking for, you know, and I personally always throw out the option, I don't ever have to see this. This can just be for you. Okay? Because if they feel like they're going to get their inventory taken because they have to show their homework, might not ever happen. Okay. I know lots of midwives, and I've worked with midwives who demand multiple food journals per trimester. And even their white middle class clients, because that was the bulk of their clients, I've never seen such crestfallen, crushed facial expressions as like, oh, I suppose you didn't bring me your food journal again.
Mm.
So it's a great tool and it can be immensely helpful. Okay. I don't even talk about it with every single one of my clients. Okay. And if I've created that conversation twice, then I drop it.
And I
What
only
about you,
use a
Quinn?
I use a food journal as in response to an identifier, right? So if I've identified that somebody has struggle getting in enough protein, I
Mhm.
might say, hey, you could use this app, you could use this food journal, put everything in that you eat. Don't try to do the math. The app will do the math for you.
Yeah.
And just keep track of it for a few days and let me know, are you hitting those milestones?
Yep.
And if you aren't, let me know which meals you are hitting those milestones in, because then I can give you some recommendations for the other meals or recommendations for a snack.
Yep.
But I was trained to do the food journal in each trimester.
Mhm.
And what I found was that Chicano women don't like being told what to do.
Mhm.
And you're never going to get a Black woman to admit to what she eats.
Yep.
So I got away from it unless there's a very specific thing. Like I have two clients that are repeat clients that are sisters-in-laws. One has cystic fibrosis and one is terribly malnutritioned. Like if
Mhm.
she's 126 pounds at 9 months pregnant, I would be surprised. And she throws 8 and 9 pound babies. So she's 90 pounds pre-pregnancy
Mhm.
weight. She has really struggled in the past to eat on any kind of a time frame. Now, this cystic fibrosis gal, those gals have an enormous range of malnutrition. So she was taking in a documented 4,400 calories a day and maybe only getting 1,900. And so a food journal for those two clients using the food app, that was very helpful to me because they could just text it to me. And they knew if I said nothing, it looked good to me. If I made some
Mhm.
tweaks, they were recommended tweaks.
Yep. This can
But
also
I
be,
got away from doing it for every client and I got away from doing it in every trimester.
yep. This could also be a conversation of an alternate option if they are, and we'll talk more about concurrent care too. But if they are going to IHS, if they do want some of the tests, A lot of the times I'll get the conversation, well, but what do you do?
Mm-hmm.
Okay. And in that conversation, that's where I'll kind of plant that seed of reflective food journaling. Well, that's one of the things that I do. Instead of the glucola, we talk about reflective food journaling. I have a glucose meter. We can talk about tracking your numbers for a week. You know? So sometimes that's where I go with that conversation too. Okay. Now, if they do have a history of GDM and they're like, well, I got put on insulin, like how can I make sure that I don't have to do that again? Okay, well, having the conversation of like that chart, okay, knowing what's physiologically supposed to happen, okay, and then talking about the nutritional aspect of insulin. Okay, what can I do to make sure that my body is producing the insulin that it needs when it's supposed to be going through that change? Well, what's point number 4? It's a sexy P word.
Protein.
Yeah, protein. Okay. If we focus on the protein load, and honestly, how I've honed my conversation is focusing it around protein. If we focus on the protein number, you don't have enough time to eat too many bad carbs, bad fats. Like if you're focusing on that number, you're going to get it in your cruciferous vegetables. You're going to get it in high fiber foods. There's that thought.
Right.
Okay.
Right.
I don't use it with all clients, but I really like the catchphrase that I caught from my twin. Eat something that had a face or came from a face because you're building a whole face. Okay. I can use it with my ranchers' wives because they totally get it. Okay. Okay. It takes flesh to build flesh. Okay. And the easiest
Yes.
way for your body to, yes, you can, yes, okay, the argument of, well, how do cows turn it into blah, 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 blah. Okay. How about we just make it easier on your body and like skip to the end?
Well, we don't have a ruminant stomach. That's how.
Well, first off, yeah, like we can't point out all the flaws of that point, but okay, let's make it easy for your body. Your body's already doing tons and tons and tons of work. Okay, let's just focus on, again, going back to how do we make the numbers seem the easiest to obtain? Because if we're talking about this, if we're talking about all this, and definitely if we were talking about this, that's so overwhelming. How I'm supposed to do that math? I'm supposed to like add 2.3 grams of extra protein per day per semester and like be an extra 10 every
Yeah.
other week.
And I can't even get my kid a bath every night.
Yeah, right. Okay. Now, there's so many more apps in the last 5 years. Okay, it's freaking awesome. And I have a form if they're and they just want to write a list. Okay, but now because I'm crouching in on my 40s, the gap between me and the bulk of my clientele is getting further, bigger. You know, it's apps. Find an app. Take notes. Okay, way easier than it used to be. Okay, but then how do we make this conversation even easier because if we're supporting in our community and the majority of their home's groceries is coming from commodities. Okay, there again, focus on the protein. Okay. I know every reservation's commodities are different. However, I think where's ours? Oh wait, I think we're in Denver district. Is that right? I don't know, whatever. But
Yes, I think so.
they do have who is it USDA? Yeah, it's USDA that
Yep.
is supposed to be in charge of commodities. All the political whatever aside, okay, there's cookbooks, online. There's a lot more cool, a lot more accessible, printable recipe cards that is specifically designed for commodities. Maybe that's something that you preemptively print out, and that's part of your paperwork care package. Okay. I'm sure if you get a hold of the USDA commod department, they'll send you a pack of, and you tell them all the, who you are, what you're doing. Like, I'm sure that they would, or your
They
commod
probably have a lot
office,
of
I'm sure you
support
could go in
material.
and
Yeah.
like take a stack of 10 of whatever printouts that they have. Okay. Simplifying the conversation. What's the one thing that would benefit the most to focus on? Protein loading. Okay. And even if they're not great cooks, and even if they don't have an auntie down the road that can help them cook or meal plan, peanut butter, the beans, the legumes, the frozen meats, the frozen chickens, like it
Yep.
kind of doesn't matter how the commodity distribution shifts from month to month. There's always a good protein load. Our office asks if there's anybody pregnant in the house, and they do like an extra quarter portion or something like that. Okay. Same with WIC. Okay, this could be an area that you collab with WIC and you pilfer some of their print material. Don't reinvent the wheel. Take what's out there.
Yep.
Okay. Herbal support. And again, I'm not throwing this out there and then leave you guys hanging, but we will talk more about herbal support versus increasing insulin and increasing sensitivity. Okay. And that's why, where'd it go? Where the,
No, you went back.
this chart.
That. Yep.
Okay, so that's why these two charts, because maternal insulin sensitivity is down, okay, knowing when that shift happens. So then knowing that, and then what she's reporting at 37 weeks, you probably wouldn't give the same herbal support if the difference between insulin production versus insulin sensitivity. That makes sense? Okay. Oh, we're there. Okay. Again, because we're focusing on physiological normals. Okay. Normal support. Okay, you're gonna be looking at the blood builders and the tissue supporters. Okay, Nora. It's pretty awesome.
Good old
The only
Nora T.
right? Everybody familiar with Nora? Nettles, oat straw,
Red
red
raspberry and
leaf, and
alfalfa.
alfalfa. Okay, blood support, tissue support. The only consideration, or I guess the only adjustment that I would make is that if she already has like a 13 or 14 hemoglobin, I'd say like, okay, you could do this once a week. Okay, right? Because once you get into that 15, 16, you might be seeing issues on the other side. There's a good level, and then there's like, okay, we need to bring it down, right? So Nora's pretty awesome. A simple variation of this, if they pre-pregnancy, so if they've had kind of that GDM label waved in front of them, okay, a really easy variation to this is add cinnamon, and there's your blood sugar regulator. Hey, stop, please. Go. Okay.
It's just not getting him.
Okay. I need a potty break, and I clearly need to yell at some kids. So
Yay.
3 minutes, 4 minutes. And
Yeah. I'm gonna see what's happening with my my sink. So Medina, is her diabetes controlled?
I think so. We didn't really get to talk too much about that.
Okay, well, she may not be then high risk if she can control it. like what might be a risk factor for them? You might have some workarounds in your support of her to remind her that if it's controlled outside of pregnancy, she can control it inside of pregnancy. She just may have to, that might look a little bit differently.
She had her prenatal appointment in Sioux Falls today, and she said that she has to take aspirin so she doesn't have
Yep, preeclampsia.
preeclampsia.
Yeah. That's all the rage right now. I mean, it actually works. In their defense, if I have some gals that are hypertensive, or have some other things where I'm kind of looking at, you know, their inability to regulate their blood pressure, I've been offering just a baby aspirin every single day as well, because some of the stuff that's out there are showing that that's one little tiny thing that you can do that makes a whole bunch of progress at the end. If you can raise the amount of actual cellular wall, which is what the aspirin does, which is why when you get a headache, it's usually because your blood vessels are constricted, right? So when your blood vessels are constricted, your blood pressure goes up. And so if they can make that cellular wall bigger by using the aspirin, then it lowers your blood pressure by design. And so women that are, women that are struggling with either salting their food or doing all the other things, I always ask them, do you think that you could take a baby aspirin every day for a couple of months? And I haven't had anybody yet say no.
We're
So
talking
it is
about
something
physiological normal today. No, I'm joking.
we're talking about her. We're segueing in the break while you were dealing with traviesos. So,
Mm.
So does that make sense, Medina,
Yes,
on why they're asking her for that?
yes.
Sorry, what was the question?
Well, they asked her to take some baby aspirin to stave off pre-E.
Mhm.
And I said that I've been doing the same. There's been some studies out in how aspirin actually functions in the blood cellular wall, that are pretty rad. And it's an easy thing
Mhm.
that you can do that kind of mitigates some of those other things that we see if a woman can't keep her blood pressure down and she's not willing to take all the mag or all the other things, and she's not salting her food
Mhm.
and she's not doing the things. I ask, would you be willing to take a baby aspirin?
Isn't the new
And
recommendation 134 a day?
yeah, I think it's no, I think it's actually 2. I think it's 162.
Oh yeah, two baby.
Yes.
Yeah, because it's
It's 81 each, right? So I think it's
yeah.
2.
Yeah, that recommendation just came out. The new altered came out like within the last 6 months, I think.
Well,
Something like
they
that.
finished that study and they're realizing that it really is kind of changing that. If you
Mhm.
think about how an aspirin affects a headache, you get a headache because you're dehydrated and your blood vessels are small, which makes your head hurt. If you can increase the size of your vascular structure, that'll bring your blood pressure down.
If you guys haven't gotten on Midwives Anonymous, I would highly recommend it, not just for the drama, but like you come across this every once in a while. But what surprised me is like now you also gotta you see a lot of the differences because there was a pretty good conversation about this new recommendation. And then some midwives are like, okay, but when do you stop? Do you stop before labor? Do you stop? Because if it's a vasodilator, okay, and she's been relying on that basically as training wheels for function for months and months and months, does that increase the risk of bleeding? Now, you see a stark line in the CPMs that carry all the groceries and are like, no, we don't bother. Like, okay, cool. Happy for you that you have all the groceries and that you can do all the things. I don't know. They get kind of uppity though, but whatever.
Well, and some of them rely on the research as like,
Gospel.
yes, like they're ominous, right? Instead
It's on
of
the
saying,
tablets, basically.
okay, if you, now I have women stop with, I have them drop down on the baby aspirin, and I've had them just taking one. I tell them that the recommendation is 2. If they still have a blood pressure problem and they're not willing to do the other things, I will up them to 2. But about 34, 35, 36 weeks, I start telling them, okay, hey, I want to see a week of no baby aspirin. Let's see what your blood pressure does. Let's see if you can maintain it.
Mhm.
I have not seen an increase in hemorrhages, but I have seen those women are a little bit more prone to trickle bleeds if they don't
Mm,
get a meal in that
definitely.
early active labor phase.
Yeah.
I mean, retrospectively, those are my own, it's my own retrospective study.
Yep.
And
Well, and I
they tend
haven't
to have
been
a little bit
supporting enough
more.
to. I haven't been supporting enough to, and I definitely wasn't doing any of that with my cannabis mom. I'm like,
Oh, Jesus, Louise, no,
oh. Anyway,
no.
anybody else step away? Everybody here?
I think everyone's back.
Okay. Okay, so creating conversation around GDM and GBS protocol. Okay. And again, we're not dangling this in front of you and then leave you hanging. We're going to revisit this many times. Okay. But we're and I think I don't remember for sure. I don't think it's in the next unit, but I know it's in the unit after that. We're gonna start having you guys do more teach backs, where we want to hear the conversations. What are you starting to gather in your knowledge base that when these conversations come up, what conversations are you creating? Okay. So we talked a little bit about the GDM, some possible conversation in the protocol that you develop or don't develop and why not. Okay. GBS, like that's going to be a big conversation and they're going to want to know why. Well, how come you don't test for it? Okay. So then creating the conversation about why is GBS physiologically normal? Okay. And we did talk a little bit about GBS in the fertility and conception counseling. Okay. This is a normal bacterium that is supposed to be in our systems. It helps our vaginal pH cleanse and re-regulate after our menstruation. Okay. It's not this big horrible beast that it's kind of been made out to be, of this dirty, gross thing that happens to randomly be in your vagina or not. Like, and pray to everybody's gods that it's not there. It's actually a pretty good thing when it's there. Okay. But there can be concerns, right? If baby gets exposed and develops reaction to it, it can be a thing, right? So I don't have any way of testing. Okay. I can't order tests. I live in an unregulated state, so that's the basis of my conversation, right? I just can't order it. If that's something that you want, you're going to have to establish care and get that test done. I can't provide that for you. Okay. So then I talk about, yes, if you want to do a protocol, if you decide that that is something that would make you feel more comfortable that you're doing something prophylactically, the big thing is probiotics, right? Regulating your gut health, because gut health is reflective in vaginal health. And probiotics in your partner. If they're still choosing to be intimate, that's a big part of it, right? The other options are herbal support, right? Echinacea and vitamin C, and tea tree oil suppositories. Okay, those are my go-to. For most women, starting at around 37 weeks is enough time.
No.
Okay. How about you, Twin?
So for GBS specifically, I talk about what I've kind of started to call safe sex practices. GBS lives in the rectum, so don't put it from the rectum, don't help it from the rectum into the vagina, either using the husband highway or the not husband highway. And we kind of just talk about how hygiene, right? Hygiene in those last few weeks can be very difficult to wipe your bottom when you can't get around back there, you know? And so we talk about whether or not they've ever been tested for GBS colonization. And if they have, I recommend Fendopolis throughout their pregnancies. I have had some women do like the garlic and tea tree oil suppositories. I've had women do like yogurt tampons. And I tell them, you know, it's a little, sometimes it's a little easier, you know, to not make marinara out of your vaginal canal. Like sometimes it's just a little bit easier if you take in those probiotics on yourself. You
Femdophilus
know,
is the female probiotic.
yes.
Yep.
And so just and looking at like how do they prioritize their hygiene, because it's not about being dirty. It's
Mhm.
about that bacteria living there for a long time. So
Yep.
99% of my GBS positive women all wear thong underwear, which makes a
And
lot of
shave.
sense. All wear
And
thong
shave.
underwear
And they shave
and
or they
shave,
wax.
and they
Mhm.
shave or they wax. So it makes a lot of sense to me when you have rectal bacteria that has a highway into the vagina, because your panties are up your butt all of the dang time, right? And then the protection that your hair offers, that your body hair offers, is not there either. And then when you shave or wax, you have microscopic cuts all over your vulva. And so that bacteria that normally lives in that region has a highway into the rest of your body. And so we just
Mhm.
talk about how some of those practices contribute to that. We also talk about that you can be positive at 37 weeks and be negative at 40, or
Mhm.
vice versa. You could be negative at 37 weeks when they test you, and you could be positive at 40. So then we talk about like water birth and what are
Mhm.
the actual GBS of the newborn is a real thing. But the first 7-day window of GBS isn't as scary to me as GBS of the neonate days 7 to 12.
Yep.
That's secondary. That's when my butt puckers a little bit, because they are right in the middle of that sleep deprivation. And they're maybe
Mhm.
not seeing some of the nuances in a baby that's very sick or getting very sick.
Mhm.
And so, I mean, as far as GDM protocol, I prioritize protein and fat. It's very,
And
very hard.
frequency.
And frequency. So it's
Yep.
very, very hard to develop some insulin resistance when you're feeding your metabolism so well and so often.
Mhm.
I have 2 glucometers, and I do offer them to various people that want them. They do a 14-day fasting and postprandial prick. And I tell them, here's the range I want you to stay at. You don't need to tell me anything unless you're outside of that range and you want some help.
Mhm.
And that's kind of how I do it. I did have that cystic fibrosis mom. You'll hear me talk about her a lot because I did a lot of things that I don't normally do. I asked her to wear a continuous glucose monitor throughout her pregnancy.
Yep. Laboring practices is usually part of my conversation with GBS as well. You know, laboring in water. Okay.
Mhm.
Sometimes it's why I might recommend an Epsom salt bath. Okay.
Yep.
If she's reporting BV or if she's reporting a concern about a UTI, I might re-recommend if she feels like she's having early labor patterns, an Epsom salt bath. Okay. The hygiene consideration. Okay.
Yep.
It's a huge reason why we don't habitually AROM gals, right? But
Right.
SROM happens, and if they don't go into active labor for more than 12 or 24 hours, you know, I do ask them to start, even if they didn't choose to do a protocol, I do ask them to start. By then, the option is echinacea and high amounts of vitamin C. Okay, because I don't want to be sticking tea tree oil up there. And
Every 4
Femdophilus is not
hours
going to
with
have,
temps. Yep.
yep, every 4 hours and take your temperature. And Femdophilus is not going to have enough time in an SROM situation to be effective.
Right. And I do echinacea at 400 milligrams, which is usually you can find them in 200 or 400s here locally. I have them do that and 250 milligrams of vitamin C, in addition to whatever they're already taking every
Mhm.
4 hours and taking their temperature. And anything over 100.4, I want to know about it.
Yep. And no more intercourse if there's an SROM
And
situation.
and nothing in the vagina, not themselves, not their husband, not a battery operated boyfriend. And I had to actually break down the battery operated boyfriend because
Yep.
I
We
said,
say
hey,
it because we've seen it happen.
yes, because I was like, hey, nothing in the vagina, no fingers, no husband, no nothing, no tongue, no nothing. Don't put anything in there. And so she told me that she developed choreo. She started running a fever. And I thought, how did my protocol not work? Like, how did this not work? And upon some further conversations with her, she let me know that she read that orgasms can bring on labor. And so she used a vibrator
Mhm.
Huh.
because
Yeah.
I said no hands and no husbands.
But you didn't say
And
no
now
vibrator.
yes,
Yep.
but
Just
I
like
didn't
why
say
now
no
we have to
vibrator.
clarify that, you know, it also means no anal intercourse. Well, you didn't say backdoor.
Yes.
No
And
joke, guys. We say it because we've
I
seen it.
tell them no rear entry vaginal sex
Mm-hmm.
because the rectum is right there. The
Yep.
penis rubs against the rectum right into the vagina, and I call it the husband highway.
Mm-hmm.
And don't let the husband highway get you in a bad way. You know, and
Yep.
I realize I tell them like, look, you might have to, you know, experiment with some different positions that are comfortable at that stage in pregnancy, but being mindful of that there and the relaxation of the rectum during sex and all of those different things and encourages or enables, maybe is a better word, the spreading of that bacteria.
Okay, we're gonna try and got like 10 minutes to get through. I don't know, a few more. We got a few more slides. Okay, so signs and assessment for breech in twins. Okay. Twins don't always, okay, so even if they did have a dating ultrasound, 10-week ultrasound, can be missed. Okay. Even if through second trimester, they're measuring where you would anticipate a singleton, it can be missed. Most of the time, by 30 weeks, you're going to start seeing big jumps. Okay. You're going to start seeing +4, +5, +6. Okay. Once your hands
Unless you're
get really
Jane.
attuned, yeah, unless you're me. Once your hands get really attuned to palpation, palpation is gonna feel super wonky,
Yes.
right?
You're going to be like, why does this baby have 2 butt cheeks?
Yeah, or where are the parts? Why is there like 8 parts here? Okay. Um, real quick review types of, or maybe this isn't a review. I can't actually remember if we ever talked about. Oh, I think in the first trimester we did.
Loosely. Yeah, loosely
Yeah,
we did.
loosely. Okay, so die, that's 2 eggs, 2 sperm. Okay, 2 eggs were released. This is the only way male-female twins can happen. Okay, 2 placentas, 2 complete sets of bags. It's
2 separate babies
genetically
born on the same day.
sometimes born on the same day, usually.
Yeah,
Okay.
usually,
Okay.
hopefully.
This is where you might see labor stop and start, but we'll talk about that when we talk about labor stuff too. Okay, but this is the only way that you can have boy-girl twins. Okay. And measurement wise, this is usually the ones that show up in measurement discrepancies early. Okay, usually ones that get missed or hide is some sort of mono twins. Okay. Mono dies. This is, well, all mono twins, 1 egg, but it depends on when they split. If they split really early, that's mono dies. If they split really late, that's mono monos. Okay. And this is where identical twins. Obviously, fraternal twins are separate. It's genetically the same as full-blooded siblings of 2 separate singleton pregnancies. They just happen to occupy the uterus at the same time.
Right.
Okay. But yeah, monos, either 1 egg and 2 sperms, that's possible. Or it's 1 egg, 1 sperm, and it either split early or it's split late. And the late split is the monos. The early split is the mono dies. If it was a 1 egg, 1 sperm type of situation. If it was a 1 egg, 2 sperm type situation, it's probably going to be a mono die because that split is going to happen really early. Like first 5-6 days.
And
Okay.
mono twins are the toughest to deal with in any setting.
Yes. Yep.
Why?
So if you see the babies, they share the inside of the amnion and the chorion. Can you guys see that? They also share a placenta. It is not a fused placenta. That is one placenta.
1 placenta.
So when baby A is born, and I personally on mono dies and mono monos, but for mono monos specifically, there is no delayed cord clamping. Baby A is sacrificing that delayed cord clamping time for baby B.
Yep.
So what happens is the placenta will still try to give blood supply. Now, not even talking about twin-to-twin transfusion and taps and all of that, right? Not the little things where they could be naughty with each other in
We're
utero.
talking about physiological normal twin.
This is physiological normal if we're talking
I
about
know,
the
I just mean
normalcy
we're
of
not
these
talking about
twins, right?
TTTS and taps.
But that's
Say that,
physiologically
but yes.
normal for mono twins, right? So when baby A comes out, we almost immediately clamp that cord because it will pull blood supply from baby B.
Yep.
There's a higher incidence of placental abruption.
The placenta has no way of shunting, of registering that one baby is breathing oxygen and one baby is not. You have a lot of unknown. Okay, those cords could be wrapped at some juncture because they've had
Around
those
each other.
fetuses.
Yeah.
Those fetuses have had complete and unfettered contact with each other. So if one's doing somersaults and one's like literally this is where you see those really gross, like, oh, this is so cool, the body's so amazing, bleh, where it's like knotted. That's
Where it
because they were
looks like
doing somersaults
crocheted.
around each other.
Yeah.
Yep. So this is also where, and again, not dangling this in front of you, but this is also where most likely you will be manually assisting high rate of potential manual assistance. High
with
rate.
that second twin.
Yep.
I have I've only done a handful of these in a birth center setting in Algodones. And every single one we went after twin B as soon as twin A was out. Now, I don't know if some of the education on that has changed, because I think that 98% of mono twins now are born via C-section, especially in this country. But in Mexico, it was not always that way. And so we always went after that second baby. Even a
Good.
vertex baby, we would push out of the way and go after them in a breech extraction.
Okay, and then this just builds on that. Okay, so you will see a lot more positional gymnastics in a monodi situation because again, they have unfettered contact with each other. Okay. But I mean, there's still a decent amount of missed. I mean, you start networking with enough midwives, there is a statistically notable occurrence of, even if they did have a 10 and a 20-week scan, missed twins. It's possible. Right. So encouraging a breech to turn. Okay. Real quick, 3 most common types of breeches: frank breech, footling breech, complete breech. Again, I'm not dangling this and leaving you hanging. We will be doing breech is a variation of physiological normal. Okay. Depending on the literature that you look at, it's 4 to 7% of births. Okay. Once you get experience, maybe you intentionally support breech, maybe you don't. But there still is always a possibility. Again, if they electively choose to never get an ultrasound, you could have a surprise breech. Okay. So that's why we are going to, regardless of if you choose to intentionally or not, okay, we're still going to teach you this because you're going to be complete midwives. And this is part of being a complete midwife. Considerations. Okay, there are times when encouraging a breech to turn might not be the best option, regardless of a singleton or breech or singleton or twin. Sometimes it's the best choice. Okay, and we will take some deep dives into breech. Okay, but I want to lay this foundation. Breech is a variation of normal. It's not a big scary thing. The biggest problem and the scariest problem with breech is an uneducated care provider. And that might be a hill we'll die on.
Yeah. And I have a different consideration on that. And I think I think what's good for you guys to see is that 2 pretty complementary care providers can see something very differently. It doesn't change how we respond to the birthing woman. But I think that variation of normal by its own definition means it's not normal. And if breech is 2 to 3% of pregnancies, then that's not a normal thing. But normal and the absence of normal does not make it automatically abnormal.
Yes, that's a better explanation actually of my view on it, because actually face presentation makes me a little bit more nervous than breech presentation.
Oh, 1000%. Coming from the woman who had a face presentation. But yeah, we want you to see that there's different ways of looking at the same thing. It doesn't have to be this us versus them consideration that you're going to get amongst CPMs and CNMs and people that are trying to normalize every single thing about birth, every single complication. Well, postpartum hemorrhage is just a variation of normal. I'm like, well, actually, if there's a variation in it, that means it's not normal by design. And to be aware of it. And we were encouraged as students to not take any breaches for our first 3 years of serving. I wasn't lucky enough to get that kind of reprieve. But it was to give us thoughts to develop our own ethical considerations, because in the state I was licensed at the time, there was not a breach law. The law was the ethical consideration of the midwife. So if the midwife felt like she could confidently serve women with breech babies, the law didn't tell her she could not do that.
Yep. And my own personal consideration of breech now, the midwife I am now, is not the same as when I was a baby midwife. Even out of my preceptorship with a midwife that was trained at the same location that Jade was trained at.
Right.
So, yeah, just laying the first conversations for that. Okay, I think we've kind of more or less incorporated this along, you know. What I will say though is when I have conversations with women who want concurrent care because I can't order these tests, I do include part of that conversation. Then I am going to ask them by 32 weeks to decide and to shift primarily either to their care or my care, because that's when our recommendations are going to start to diverge drastically. Understandably so. I mean, it's two different methodologies and it's two different environments of support. So for me, that's my kind of hard line, is like, okay, I understand why you want these tests. You know, obviously those numbers are helpful to me, can be helpful to me too. But I am going to, by 32 weeks, like,
Yep. Please pick a
you're
side.
gonna have to shift. It's either all me or it's all them, you know. Because I don't want to be spending 2/3 of my prenatal recovering from what the OB said at their 36-week checkup.
Right.
Okay. Charting. We will have a good portion of our hands-on practice with charting too. And we are going to incorporate some charting in these case studies. I'm like 97% sure I posted my charts, right, guys? I'm pretty sure I did. Probably last unit, I think. I don't remember. But we did talk about, you know, figuring out what kind of charts, starting to look at charts,
Right.
developing your own charts potentially. Okay. Okay. Yep. I kind of wanted to blaze through that one because this is another revisit back to RH factor. Okay, so RH negative mom has an RH positive husband. This is the only combination where there's this potentiality of concern. If the mom is RH positive and the dad is RH negative,
Don't matter.
it's not going to matter. Okay. And Teeny, please go get your sister.
And if mom is negative and dad is negative,
Then it's
it
extra not gonna
also
matter.
technically should not matter.
Yep. And where it can matter in subsequent pregnancies is if she's had a successful birth and the baby was RH positive and she developed titers. Okay. And again, I'm not dangling this and ditching. When we do our unit on placenta, we're going to take a deep dive into this. But we're revisiting this because it takes a few revisits to get this solidified. I mean, it definitely did for me. Right? What gets talked about even less is ABO incompatibility, because that's not necessarily dependent on RH factor. It's a blood type O mom. Please take him. Okay.
With a dad with
And
AB or AB.
Yep.
And the positive or negative cofactors do not matter.
Not for ABO incompatibility. Okay. So if they have a history of like, yeah, my baby had jaundice for like months and we couldn't get it to come down, that's your first indicator that she, okay, what's your blood type? Oh, O positive. Weird, couldn't call that.
And I usually say, is your husband A, B, or AB? And they're like, oh my gosh, how'd you know?
Yeah. So what's happening here is the baby's liver, okay, because that's how babies, regardless of what type of jaundice it is, the liver is what filters it out, right? The blood type, literally incompatibility, is how do I succinctly explain this?
It's fetal, it comes back down to fetal circulation.
Yeah.
It goes through
Yep.
the mom goes back through the baby, and those things, the baby has a hard time processing all the extra things in the mom's blood. So it all comes back to fetal circulation, which is where the RH incompatibility comes back in too, right? But you can have an ABO incompatibility without injury. Whereas
Yes.
in an RH incompatibility, you're likely going to have a mom, if she is sensitive for antigens and developing antibodies, it's usually due to some type of injury or blood mixing.
Mm-hmm.
Whereas in an ABO, sometimes it just happens.
And for ABO incompatibility, a majority of the time, it's yeah, it was just like lingering jaundice, like they stayed lemony for a really long time, or
Yep.
um yeah, so lingering jaundice by like even past the 6-week postpartum
Mm-hmm.
checkup. It's like potentially 2 months, 3 months of just that lingering, not quite all the way gone, yellowish tint to baby. Okay. Okay. So that's the end of the topics.
Any questions on those?
Okay. Try and wrap this up in like 5 minutes or less. We're almost there, guys. Okay, so
Yeehaw.
what's next? Okay, so in the outline, it talked about creating childbirth education. I will open a submission box for an outline. Okay, that's all we're asking for right now is an outline. Okay. Guideline thoughts. Okay, there's not a grading rubrics. Okay, but guideline thoughts. I'm going to encourage you to kind of approach this with two different intentions. Kind of a faster, maybe half hour, 45-minute outline that gets incorporated into your prenatal care. And then potentially like a 1 hour, 2 hour format in case for families that specifically want a whole prenatal or sometimes a separate little mini workshop for
Right.
childbirth ed,
Yep.
childbirth prep. So that's going to be my encouragement is to have it and they can be incorporated, like the short version can be incorporated into log version. I'm not going to, say that it has to be completely different from each other. I mean, because they're not. Childbirth ed is childbirth ed, right? And look up some resources, look up some structures, make an outline that reflects you as a midwife, the care that you provide. Okay, because how I talk about childbirth ed might not make sense to you, your community, or make sense to your brain how to explain something. Right? If you do choose to incorporate spiritual, cultural, community practices, again, I'm not going to ask you to spell it out, but just put a reference notation, story about the moon or, cultural practice. Like, I'm never gonna ask you to spill your guts about, you can share whatever you want to share. Does that make sense? Oh my gosh, it's the worst. Okay. Anything else for you about this, Twinsy?
No, I actually quit offering childbirth ed. So, but I think I think when you're creating your childbirth ed, it gives you a really good idea of how you're going to midwife a woman in labor.
Mm-hmm.
And it gives you an idea of kind of the physiological stages of labor that happen. And as you're teaching this, you're actually sharing a part of yourself in how you're going to midwife them. And that's where I think that midwives creating their own childbirth education is a good thing. Especially for native midwives, probably even more so, because it does give you a segue and an opportunity to incorporate your cultural teachings and your spiritual practices in a time when they're going to be the most receptive. Because in
Mhm.
labor, they may be on another planet.
Mhm.
And so,
And having
know,
one that you incorporate into prenatal care can be a huge, huge opportunity for moms and their partners to voice and engage in questions that they might not have found another way of oh my God, of starting that conversation or voicing that question. Right?
yes, absolutely, Medina. Incorporating preconception education
Yeah.
is part of that,
Yep.
because we're looking at it from a holistic, from the very beginnings. The very beginnings of your pregnancy don't begin with conception. They begin when you start thinking about
Froze up. Unfreeze now.
feeling them around us.
Okay, rewind 2 thoughts. You froze
Okay,
up.
so I said that we believe that conception isn't the start of your pregnancy, right? The start of your pregnancy is in your inklings of wanting another person to join your family. Like, we believe that children choose us. So we believe that children kind of hang around us spiritually. And that kind of puts the extra little oomph in, like, hey, I feel a baby hanging around. We should probably get to business and get them here, And so I think that preconception education is the very beginnings of childbirth ed.
Yep. And I mean, I have a
Depending
lot
on
of
what your
very parallel
practices are,
beliefs.
right?
Yeah, I have a lot of parallel beliefs. Unfortunately, we don't get to be very often. We don't get to be those parts of conversations. But I do think that there is still a value in talking about those things, regardless of when a child CBE specific conversation happens. Okay. Case studies 5 and 6. We'll post them on Sunday, no later than noon. So you actually get more than 24 hours. And those submission box will be open until 23:59. And then the call about it will be next Wednesday. As before, please do the 4 summation topics. And this is where we also want to see how are you going to make these notes in your charts. Okay. Are you just how are you going to include this conversation in your chart? Because these conversations aren't during the prenatal. Okay. And then your response to the client too. So we're adding that one topic header of chart notes. Now you can either tell us this is what I'm going to write. You can show us, you can, however you want to represent how you're going to include that in your chart. That's up to you guys. Yep. Any questions about that? Right, and then the quiz. So this will be the image that the quiz is on. Okay. Now, why am I picking this angle? Because this is the only angle that you're gonna get if you do a vaginal exam. And we want to know, okay, we want to start the conversation of knowing the landmarkers. If you do a vaginal exam, obviously this is something that we're probably, well, we are going to incorporate this in the hands-on. Okay, but any questions about this? This will be the image that the quiz is.
Is that what you call the vault?
What's that?
Is that what you call the vault?
The vault is the vagina.
Yeah, when Jade says hanging out in the vault, she means like halfway through the vagina, just
Yeah.
before crowning happens. So definitely past the cervix, but just before you start seeing the head. That's definitely a Jade-ism. That's not a
It is a
technical
Jade-ism.
term. It's a Jade-ism. Hanging out in the vault. There's no
Just
cervix
hanging out in
left.
the vault too
but we
long.
can't quite see the head. Okay. And then lastly, our first in-person skills weekend will be this November 7th through the 10th. The 7th, 8th, and 9th will definitely, so that's the 7th is Friday. So Friday, Saturday, Sunday will definitely be teaching days, and we'll be starting the morning of the 7th. I haven't figured out everything that we're gonna do yet, so the 10th may or may not be a teaching day or a full teaching day. But I can't not guarantee that we won't teach on the 10th. Does that make sense? If anything gets shifted, we won't have anything to teach on the 10th, but I'm guessing that most of us will need it at least as a travel day. Does that make more sense? I don't know. Maybe not.
Well, everybody's here. Is anybody else going to have a RV to attend the that week? And
I sold mine, so I don't have mine anymore.
okay,
Oh darn. Could have been neighbors the weekend.
I got a teepee though.
Yeah, you do, and you put it up all by yourself.
Heck
I've
yeah.
seen it.
Yep. I don't need no stinking mang.
Okay. So, mark your calendars. The 7th, 8th, and 9th will definitely be teaching days. Definitely. So we'll be starting the morning of the 7th.
and we will be in our suite 14 on those days.
Oh, nice. I love your office space.
Yeah, it's big enough for all of us and to move around and set up stations. So instead of hauling everything here and there.
Where'd you
Good.
get these pictures?
Did
Oh, I'm a
she's
picture ninja. Yeah. I get booby trapped a lot. What else am I gonna do except for look for pictures? Okay, any questions about the last few slides about? No?
When, and where can we see the recordings? So like whatever I missed out on the first part.
I have been sending them from the school email.
I've only gotten one myself of the recordings.
Yeah, same.
I
Aren't
will.
they, are they uploaded into Teachable when we record them?
Nope, I can't.
Mhm.
Can't.